Good afternoon, let's start the lecture. Second unit. The circulation. Chapter 3. The normal electrocardiogram. Study of electrical properties of the myocardium. This lecture can be found on the Normal Physiology course website. Guyton and Hall. Textbook of Medical Physiology. Pages 123 to 157. You can also familiarize yourself with this topic with this tutorial. There are a huge number of books and websites dedicated to ECG. A student can simply drown in this ocean of information. Electrocardiography is among the most valuable clinical tests available to medicine because it is quick, completely safe, painless, inexpensive, and rich in information. Etymology. The word is derived from the Greek elektro, meaning related to electrical activity, cardia, meaning heart, and graph, meaning to write. Abbreviations of electrocardiography and electrocardiogram are ECG and EKG, abbreviated from the German word Elektrokardiografie. Not to be confused with echocardiography, electroencephalography, EEG, or electromyography, EMG. Electrocardiography, definition. Electrocardiography is the recording of the electrical activity of the heart. It is based on recording of electric potentials generated by heart on different body parts, mostly on body surface. Don't forget electrical potentials. It is important to know. ECG recorders use millivoltmeters for measure the electrical potentials of body. An ECG is graphic record of the electrocardiography. An ECG is a graph, conditional in this picture, of the dependence of the potential difference, millivolts, on the ordinate axis on time, seconds, on the abscissa axis. Let's say it again. An ECG is graphic record of the electrocardiography. An ECG is a graph, conditional in this picture, of the dependence of the potential difference, millivolts, on the ordinate axis on time, seconds, on the abscissa axis. Background grid. ECGs are normally printed on a grid. The horizontal axis represents time and the vertical axis represents voltage. The sweep speed of the ECG signals displayed on the display with a constant image can be 50, 25, 12.5 and 6.25 mm per second. Two large blocks equal 1 mV. Each small block equals 0.1 mV. A small box is 1 mm times 1 mm and represents 0.1 mV times 0.02 seconds. A large box is 5 mm times 5 mm and represents 0.5 mV times 0.20 seconds. The large box is represented by a heavier line weight than the small boxes. ECG. What properties of the myocardium are being studied? Electrical properties of the heart. Rhythmic activity or automaticity, chronotropia. Excitability, bathmotropia. Conductibility, dromotropia. These are the properties that are studied in electrocardiography, ECG. Mechanical properties of the heart. Contractility, inotropia. Relaxation, lusitropia. These are the properties that are studied during echocardiography, ultrasound examination of the heart. Remember, electrocardiography is not used to study the mechanical properties of the myocardium. A concise history of the ECG. Willem Einthoven invented the first practical electrocardiogram in 1903. Willem Einthoven received the Nobel Prize in Medicine in 1924 for it. An early commercial ECG device, 1911. Rather than using today's self-adhesive electrodes, Einthoven's subjects would immerse each of their limbs into containers of salt solutions from which the EG was recorded. Heart is an electric generator. The human heart is now documented as the strongest generator of both electrical and magnetic fields in the body. The heart is about 100,000 times stronger electrically and up to 5,000 times stronger magnetically than the brain. As soon as an area of myocardium becomes depolarized, negative charges make this part of the surface electronegative. Electric charges generate time-varying electric fields. The concept of an electric field was introduced by Michael Faraday. An external electric field of the heart. In 1887, Augustus Waller invented an ECG machine consisting of a Lippmann capillary electrometer fixed to a projector. The trace from the heartbeat was projected onto a photographic plate that was itself fixed to a toy train. This allowed a heartbeat to be recorded in real time. Waller showed distribution potentials of the heart on the surface of the body. In the picture, isopotential map in 40 milliseconds after the excitation of the myocardium. An external electric field of the heart changes during the cardiac cycle. Registration system of human body's electrical potentials which are formed by heart. How to place ECG electrodes. An electrode is an electrical conductor used to make contact with a non-metallic part of a circuit, e.g. a skin of patient. The word was coined by the scientist Michael Faraday from the Greek words elektron, meaning ember, from which the word electricity is derived, and hodos, away. The study of the conduction system of the heart is called cardiac electrophysiology, EP. An EP study is performed via a right-sided cardiac catheterization. A wire with an electrode at its tip is inserted into the right heart chambers from a peripheral vein, and placed in various positions in close proximity to the conduction system so that the electrical activity of that system can be recorded. Standard catheter positions for an EP study include high right atrium, or HRA, near the sinus node, a His across the septal wall of the tricuspid valve to measure bundle of His, a coronary sinus, into the coronary sinus, and a right ventricle, in the apex of the right ventricle. The location of the electrode in the esophagus during transesophageal ECG. An esophageal lead can be inserted to a part of the esophagus where the distance to the posterior wall of the left atrium is only approximately 5 to 6 mm, remaining constant in people of different age and weight. An esophageal lead avails for a more accurate differentiation between certain cardiac arrhythmias, particularly atrial flutter, AV nodal reentrant tachycardia, and orthodromic atrioventricular reentrant tachycardia. It can also evaluate the risk in people with Wolff-Parkinson-White syndrome, as well as terminate supraventricular tachycardia caused by re-entry. Body surface potential mapping, BSPM, has a long and rich history as a non-invasive technique used to sample the heart's electrical activity by sampling over the entire surface of the thorax. There are numerous reviews that cover the history and utility of BSPM. BSPM differentiates from other forms of electrocardiograms, ECGs, by its comprehensive acquisition of bioelectric potentials with the goal of capturing all that is available from the body surface, at the cost of substantial redundancy in information. BSPM was first reported widely by Descartes et al. As a tool to demonstrate the inadequacies of single dipole source models to describe cardiac electric sources, and many other investigators have demonstrated its superior ability to reveal a wide range of pathologies. Despite its advantages, BSPM is rarely available as part of routine clinical management. However, it remains a useful tool for both research studies and as the input for an imaging modality that seeks to reconstruct cardiac electrical activity non-invasively. The analysis approaches. Let's repeat the above. Body surface potential mapping, BSPM, has a long and rich history as a non-invasive technique used to sample the heart's electrical activity by sampling over the entire surface of the thorax. There are numerous reviews that cover the history and utility of BSPM. BSPM differentiates from other forms of electrocardiograms, ECGs, by its comprehensive acquisition of bioelectric potentials with the goal of capturing all that is available from the body surface, at the cost of substantial redundancy in information. BSPM was first reported widely by Descartes et al. As a tool to demonstrate the inadequacies of single dipole source models to describe cardiac electric sources, and many other investigators have demonstrated its superior ability to reveal a wide range of pathologies. Despite its advantages, BSPM is rarely available as part of routine clinical management. However, it remains a useful tool for both research studies and as the input for an imaging modality that seeks to reconstruct cardiac electrical activity non-invasively. Traditionally, ECG usually means a 12-lead ECG taken while lying down as discussed below. However, other devices can record the electrical activity of the heart such as a Holter monitor, but also some models of smartwatch are capable of recording an ECG. ECG signals can be recorded in other contexts with other devices. In a conventional 12-lead ECG, 10 electrodes are placed on the patient's limbs and on the surface of the chest. The standard 12-lead ECG. In this photo, school children perform classical electrocardiography. Their scientific work on vector analysis of ECG was twice recognized as the best at the All-Russian competition under the presidential program, Step into the Future. 10 electrodes are used for a 12-lead ECG. The 4 extremity electrodes. The 6 chest electrodes. Do not confuse following items. Electrode is a part of ECG device, which is placed on, or inside, patient's body to record the electric potentials. Lead is a junction of parts of human's body on which potentials are registered and measured. Axis of leads is an imaginary straight line that connects active and passive poles of leads, electrodes. Electrodes and leads. Electrodes and leads. Electrodes are the actual conductive pads attached to the body surface. Any pair of electrodes can measure the electrical potential difference between the two corresponding locations of attachment. Such a pair forms a lead. However, leads can also be formed between a physical electrode and a virtual electrode, known as Wilson's central terminal, WCT, whose potential is defined as the average potential measured by 3 limb electrodes that are attached to the right arm, the left arm, and the left foot, respectively. ECG color codes explained. In this lecture, we will try and demonstrate about the different color code used in different international standards for ECG lead wires. Since the introduction of string galvanometer, ECG is most commonly conducted diagnostic procedure and fundamental tool for clinical practice. ECG lead misplacement can result in significant harm to the patient if essential treatment is withheld or if the incorrect treatment is delivered solely on the basis of ECG findings. History of ECG color codes. ECG procedure is an important step in ensuring the high level of precision required and expected by clinicians and their patients. Recognizing the importance of the same leading standardizing bodies, IEC and ANSI, in the world have initially issued their own standards. The International Electrotechnical Commission, IEC, is one of the world's leading organizations that prepares and publishes international standards for all electrical, electronic, and related technologies. IEC released standards for ECG devices in year 1993, namely IEC 6066061-2-25. The American National Standards Institute, ANSI, and the Association for the Advancement of Medical Instrumentation, AAMI, together published first standard for ECG device in the year 1991, namely EC 11. Since both the bodies have issued different standards for their respective operating countries during different times, they have followed different logic in naming the color codes for ECG lead/cable placements. Even though these standards have gone through many revisions, the discrepancy remains. Since the manufacturers from respective affiliated countries follow either of IEC or ANSI, the device importing countries experience conflicting color codes. Below picture representations will help you understand the difference and can help you place the leads in proper manner. Inscription and color coding of the ECG leads. 2 systems for ECG lead color coding are used. The AHA, American Heart Association, system. The IEC, International Electrotechnical Commission, system. Note, we use the IEC system. Color and letter coding of limb lead electrodes. Color and letter coding is used for quick and correct selection of the electrodes. Different colors, color and letter, are preferred in Europe and USA. In Europe, red for right arm, R, yellow for left arm, L, green for left leg, F, foot, black for right leg, N, neutral. Electrodes are never placed on the feet. But the electrode on the left leg is marked with the letter F, foot. In USA, white for right arm, RA, black for left arm, LA, red for left foot, LL, green for right leg, RL. Table of color and letter coding for 10 electrodes in Europe and the USA. Often the presented systems are mixed. For example, the European letter coding of the limb electrodes, R, L, F, and used together with the American coding of the chest, precordial, electrodes, V1, V2, V3, V4, V5, V6. Limb electrode placement. Limb electrode placement. R, on the right arm, avoiding thick muscle. L, in the same location where R was placed, but on the left arm. F, on the left leg, lower end of inner aspect of calf muscle. Avoid bony prominences. N, in the same location where F was placed, but on the right leg. To remember the color coding of the limb leads, use this mnemonic. Proper placement of the limb electrodes. The limb electrodes can be far down on the limbs or close to the hips, shoulders, as long as they are placed symmetrically. HEST, precordial, electrode placement. The 6 chest electrodes. The chest leads are also color-coded, but researchers rely more on labeling the electrodes with letters and numbers from C1 to C6. To explain the locations of the active, plus, chest electrodes, we will use a picture from the internet. Please note that in picture B, the anterior chest wall with electrodes is drawn from below and the back from above. This is unfortunately typical of ECG textbooks. We'll fix that and flip this drawing over. We have turned the picture B over and are looking at a horizontal section of a person from below. This is how horizontal CT scans are placed during analysis, C. This correct placement of the slice will help us a lot when we study the rotation of the heart around the vertical axis, in the horizontal plane. V1, or C1, electrode. In the fourth intercostal space, between ribs 4 and 5, just to the right of the sternum, breastbone. V2, or C2, electrode. In the fourth intercostal space, between ribs 4 and 5, just to the left of the sternum. V3, or C3, electrode. Between leads C2 and C4. Therefore, place this electrode after installing electrodes V2 and V4. V4, or C4, electrode. In the fifth intercostal space, between ribs 5 and 6, in the midclavicular line. Official recommendations are to place C4 under the breast in women. V5, or C5, electrode. Horizontally even with C4, in the left anterior axillary line, so not necessarily in the fifth intercostal space. V6, or C6, electrode. Horizontally even with C4 and C5 in the mid-axillary line, so not necessarily in the fifth intercostal space. Once again we draw your attention. We place chest electrodes V5 and V6 strictly at the horizontal level of electrode V4. The placement of electrodes V5 and V6 in the fifth intercostal space is a fairly common mistake. Don't make this mistake. ECG leads. 10 electrodes, 9 active and 1 neutral, create 12 leads. Standard ECG 12-lead system is the group of the 3 systems. Eindhoven bipolar extremity leads, I, 2, 3. Goldberger augmented extremity leads, AVR, AVL, AVF. Wilson unipolar chest leads, V1, V2, V3, V4, V5, V6. Leads 1, 2, and 3 are called the limb leads. The electrodes that form these signals are located on the limbs, one on each arm and one on the left leg. The limb leads form the points of what is known as Eindhoven's triangle. Lead 1 is the voltage between the positive left arm, L, electrode and right arm, R, electrode. Lead 2 is the voltage between the positive left leg, F, electrode and the right arm, R, electrode. Lead 3 is the voltage between the positive left leg, F, electrode and the left arm, L, electrode. On this slide you can read almost everything I said on the previous slide or listen to it again. Eindhoven bipolar extremity leads. Leads 1, 2, and 3 are called the limb leads. The electrodes that form these signals are located on the limbs, one on each arm and one on the left leg. The limb leads form the points of what is known as Eindhoven's triangle. Lead 1 is the voltage between the positive left arm, L, electrode and right arm, R, electrode. Lead 2 is the voltage between the positive left leg, F, electrode and the right arm, R, electrode. Lead 3 is the voltage between the positive left leg, F, electrode and the left arm, L, electrode. Leads AVR, AVL, and AVF are the augmented limb leads. They are derived from the same 3 electrodes as leads 1, 2, and 3, but they use Goldberger's central terminal as their negative pole. Goldberger's central terminal is a combination of inputs from 2 limb electrodes, with a different combination for each augmented lead. It is referred to immediately below as the negative pole. Lead augmented vector right, AVR, has the positive electrode on the right arm. The negative pole is a combination of the left arm electrode and the left leg electrode. Lead augmented vector left, AVL, has the positive electrode on the left arm. The negative pole is a combination of the right arm electrode and the left leg electrode. Lead augmented vector foot, AVF, has the positive electrode on the left leg. The negative pole is a combination of the right arm electrode and the left arm electrode. Together with leads I, 2, and 3, augmented limb leads AVR, AVL, and AVF form the basis of the hexaxial reference system, which is used to calculate the heart's electrical axis in the frontal plane. Older versions of the nodes, VR, VL, VF, use Wilson's central terminal as the negative pole, but the amplitude is too small for the thick lines of old ECG machines. The Goldberger terminals scale up, augments, the Wilson results by 50%, at the cost of sacrificing physical correctness by not having the same negative pole for all three. Leads AVR, AVL, and AVF are the augmented limb leads. They are derived from the same three electrodes as leads 1, 2, and 3, but they use Goldberger's central terminal as their negative pole. Goldberger's central terminal is a combination of inputs from two limb electrodes, with a different combination for each augmented lead. It is referred to immediately below as the negative pole. Lead augmented vector right, AVR, has the positive electrode on the right arm. The negative pole is a combination of the left arm electrode and the left leg electrode. Lead augmented vector right, AVR, has the positive electrode on the right arm. The negative pole is a combination of the left arm electrode and the left leg electrode. Lead augmented vector left, AVL, has the positive electrode on the left arm. The negative pole is a combination of the right arm electrode and the left leg electrode. Lead augmented vector foot, AVF, has the positive electrode on the left leg. The negative pole is a combination of the right arm electrode and the left arm electrode. Together with leads 1, 2, and 3, augmented limb leads AVR, AVL, and AVF form the basis of the hexaxial reference system, which is used to calculate the heart's electrical axis in the frontal plane. Older versions of the nodes, VR, VL, VF, use Wilson's central terminal as the negative pole, but the amplitude is too small for the thick lines of old ECG machines. The Goldberger terminals scale up, augments, the Wilson results by 50%, at the cost of sacrificing physical correctness by not having the same negative pole for all three. The chest leads lie in the transverse, horizontal, plane, perpendicular to the other six leads. The six precordial electrodes act as the positive poles for the six corresponding precordial leads, V1, V2, V3, V4, V5, and V6. Wilson's central terminal is used as the negative pole. Recently, unipolar precordial leads have been used to create bipolar precordial leads that explore the right to left axis in the horizontal plane. The chest leads lie in the transverse, horizontal, plane, perpendicular to the other six leads. The six precordial electrodes act as the positive poles for the six corresponding precordial leads, V1, V2, V3, V4, V5, and V6. Wilson's central terminal is used as the negative pole. Recently, unipolar precordial leads have been used to create bipolar precordial leads that explore the right to left axis in the horizontal plane. Additional electrodes may rarely be placed to generate other leads for specific diagnostic purposes. Right-sided precordial leads may be used to better study pathology of the right ventricle or for dextrocardia, and are denoted with an R, example V5R. Posterior leads, V7 to V9, may be used to demonstrate the presence of a posterior myocardial infarction. A Lewis lead, requiring an electrode at the right sternal border in the second intercostal space, can be used to study pathological rhythms arising in the right atrium. Elements or components of ECG. Elements of ECG. Waves. Segments. Intervals. Elements of ECG. Waves are parts of ECG, which are located above or below the isoline. Segments are parts of ECG, which are located on the isoline. Intervals include waves and segments. Waves of ECG. P wave represents atrial depolarization. QRS complex represents ventricular depolarization. T wave represents ventricular repolarization. U wave represents repolarization of the papillary muscles or Purkinje fibers. Waves of ECG. P wave represents atrial depolarization. QRS complex represents ventricular depolarization. T wave represents ventricular repolarization. U wave represents repolarization of the papillary muscles or Purkinje fibers. Waves P and T can be positive, negative, isoelectric, biphasic. QRS complex has a series of three deflections. The first deflection, if it is negative, is called a Q wave. The positive deflections is called an R waves. A negative deflection after an R wave is called an S wave. A second positive deflection after the S wave, if there is one, is called the R' wave. QRS complex. Some QRS complexes do not have all three types of deflections. But irrespective of the number of waves present, they are all QRS complexes. A. Typical electrocardiogram in the second lead according to Einthoven. B. Typical electrocardiogram in lead AVR according to Goldberger. Answer. 1. Negative wave P. 2. Small wave R, the first positive wave of the complex of ventricular depolarization waves, QRS, less than 0.5 mV. 3. Negative wave S of the ventricular depolarization complex, QRS, more than 0.5 mV, which follows the wave R2. 4. R', second positive wave of the ventricular depolarization complex, QRS, less than 0.5 mV. And finally 5. Negative wave T. All positive waves of the ventricular depolarization wave complex are designated by large or small r waves. Negative waves of the complex of ventricular depolarization waves are indicated by large or small waves Q, if this is the first wave of the complex, or S, if this negative wave follows the wave R. A. Typical electrocardiogram in the second lead according to Einthoven. B. Typical electrocardiogram in lead AVR according to Goldberger. Look carefully at the labels for ventricular depolarization complexes. Practice labeling ventricular depolarization complexes on tests. Now I want to draw your attention only to some complexes. How would you describe the ventricular depolarization complexes? Answer. A, R, B, QR. How would you describe the ventricular depolarization complexes? Answer. A, Q is small and S is large. B, Q big and S small. How would you describe the ventricular depolarization complexes QRS? Answer. A, R, S, R, S. B, R, R, S. Segments of ECG. PQ or PR. ST or JT. TP. The junction between the end of the QRS and the beginning of the ST segment is called the J point. Intervals of ECG. RR. PQ or PR. ST or JT. TP. QT. The QT interval is a measure of the time between the start of the Q wave and the end of the T wave. The QT interval represents electrical depolarization and repolarization of the ventricles. A lengthened QT interval is a marker for the potential of ventricular tachyarrhythmias like torsades de points and a risk factor for sudden death. The mechanism of formation of elements of the ECG.
The mechanism of formation of elements of the ECG. Surface ECG reflects only the excitation processes working myocardiocyte's heart. Relationship between cardiac muscle action potentials and ECG. A variety of potentials form the ECG, but these are only plateau-shaped action potentials of contractile myocytes.
Relation of the monophasic action potential of ventricular muscle to the QRS and T waves in the standard electrocardiogram. Let's study this question using Guyton and Hall's textbook. Figure 11-3 pages 124-125. Above, monophasic action potential from a ventricular muscle fiber during normal cardiac function, showing rapid depolarization. And then repolarization occurring slowly during the plateau stage, but rapidly toward the end. Below, electrocardiogram recorded. Simultaneous. The monophasic action potential of ventricular muscle, discussed in Chapter 10, normally lasts between 0.25 and 0.35 second. The top part of figure 11-3 shows a monophasic action potential recorded from a microelectrode inserted to the inside of a single ventricular muscle fiber. The upsweep of this action potential is caused by depolarization, and the return of the potential to the baseline is caused by repolarization. Note in the lower half of the figure a simultaneous recording of the electrocardiogram from this same ventricle, which shows the QRS waves appearing at the beginning of the monophasic action potential and the T wave appearing at the end. Note especially that no potential is recorded in the electrocardiogram when the ventricular muscle is either completely polarized or completely depolarized. Only when the muscle is partly polarized and partly depolarized does current flow from one part of the ventricles to another part, and therefore current also flows to the surface of the body to produce the electrocardiogram. Let's consider this issue in more detail. The P wave corresponds to phases, fast depolarization, and phase 1, initial repolarization, of the action potentials of atrial cardiomyocytes and phase 4, resting potential, of the action potential of ventricular cardiomyocytes. The PQ segment corresponds to phase 2, plateau, depolarization state, of the action potentials of atrial cardiomyocytes and phase 4, resting potential, of the action potential of ventricular cardiomyocytes. The QRS complex corresponds to phase 3, final repolarization, of the action potentials of atrial cardiomyocytes and phase 0, fast depolarization, and phase 1, initial repolarization, of the action potential of ventricular cardiomyocytes. The ST segment corresponds to phase 4, resting potential, of the action potentials of atrial cardiomyocytes and phase 2, plateau, depolarization state, of the action potential of ventricular cardiomyocytes. The T wave corresponds to phase 4, resting potential, of the action potentials of atrial cardiomyocytes and phase 3, final repolarization, of the action potential of ventricular cardiomyocytes. The TP segment corresponds to phase 4, resting potential, of the APS of atrial cardiomyocytes and phase 4, resting potential, of the APS of ventricular cardiomyocytes. Let's consider this issue in more detail. The P wave corresponds to phases, fast depolarization, and phase 1, initial repolarization, of the action potentials of atrial cardiomyocytes and phase 4, resting potential, of the action potential of ventricular cardiomyocytes. The PQ segment corresponds to phase 2, plateau, depolarization state, of the action potentials of atrial cardiomyocytes and phase 4, resting potential, of the action potential of ventricular cardiomyocytes. The QRS complex corresponds to phase 3, final repolarization, of the action potentials of atrial cardiomyocytes and phase 0, fast depolarization, and phase 1, initial repolarization, of the action potential of ventricular cardiomyocytes. The ST segment corresponds to phase 4, resting potential, of the action potentials of atrial cardiomyocytes and phase 2, plateau, depolarization state, of the action potential of ventricular cardiomyocytes. The T wave corresponds to phase 4, resting potential, of the action potentials of atrial cardiomyocytes and phase 3, final repolarization, of the action potential of ventricular cardiomyocytes. The TP segment corresponds to phase 4, resting potential, of the APS of atrial cardiomyocytes and phase 4, resting potential, of the APS of ventricular cardiomyocytes. Relation of the action potential of cardiac muscle to the ECG. This is what you need to know to understand the ECG. What is indicated by the numbers? Relation of the action potential of cardiac muscle to the ECG. This is what you need to know to understand the ECG. What is indicated by the numbers? Answer. A. Electrocardiogram, ECG. 1. Wave P. 2. Segment PQ. 3. Complex of waves QRS. 4. Segment ST. 5. Wave T. 6. Segment TP. B. Representative action potential of an atrial myocardiocyte, fast response. 7. Phase 4, resting membrane potential, RMP. 8. Phase 0, rapid regenerative depolarization. 9. Phase 1, initial repolarization. 10. Phase 2, plateau. 11. Phase 3, final repolarization. 12. Phase 4, resting membrane potential, RMP. C. Representative action potential of a ventricular myocardiocyte, fast response. 13. Phase 4, resting membrane potential, RMP. 14. Phase 0, rapid regenerative depolarization. 15. Phase 1, initial repolarization. 16. Phase 2, plateau. 17. Phase 3, final repolarization. 18. Phase 4, resting membrane potential, RMP. Answer. A. Electrocardiogram, ECG. 1. Wave P. 2. Segment PQ. 3. Complex of waves QRS. 4. Segment ST. 5. Wave T. 6. Segment TP. B. Representative action potential of an atrial myocardiocyte, fast response. 7. Phase 4, resting membrane potential, RMP. 8. Phase 0, rapid regenerative depolarization. 9. Phase 1, initial repolarization. 10. phase 2, plateau. 11, phase 3, final repolarization. 12, phase 4, resting membrane potential, RMP. C. Representative action potential of a ventricular myocardiocyte, fast response. 13, phase 4, resting membrane potential, RMP. 14, phase 0, rapid regenerative depolarization. 15, phase 1, initial repolarization. 16, phase 2, plateau. 17, phase 3, final repolarization. 18, phase 4, resting membrane potential, RMP. Thus, when the PQ segment, blue, is formed, the atria are in phase 2, plateau, and the ventricles are in phase 4, resting potential. When the ST segment is formed, red, the atria are in phase 4, resting potential, and the ventricles are in phase 2, plateau. During the formation of the TP segment, green, and the atria are and the ventricles are in phase 4, resting potential. The atrial waveform, relationship to the P wave. Atrial depolarization proceeds sequentially from right to left, with the right atrium activated before the left atrium. The right and left atrial waveforms summit to form the P wave. The first 1/3 of the P wave corresponds to right atrial activation, the final 1/3 corresponds to left atrial activation, the middle 1/3 is a combination of the two. Right atrial enlargement, lead to. In right atrial enlargement, right atrial depolarization lasts longer than normal and its waveform extends to the end of left atrial depolarization. Although the amplitude of the right atrial depolarization current remains unchanged, its peak now falls on top of that of the left atrial depolarization wave. The combination of these two waveforms produces a P waves that is taller than normal, more 2.5 mm, although the width remains unchanged, less 120 milliseconds. Left atrial enlargement, lead to. In left atrial enlargement, left atrial depolarization lasts longer than normal but its amplitude remains unchanged. Therefore, the height of the resultant P wave remains within normal limits but its duration is longer than 120 milliseconds.